So welcome. I think we've set a new record for registrations for this, the fourth in our winter seminar. I guess it's now spring seminar series through the International Society of Electrocardiology. I'm Rob McLeod. It's my pleasure to moderate today, and participants are rolling in. We're up to 60 already, and I'm sure we'll have a number more joining us as we get going. Again, welcome to everyone from around the world. This is kind of amazing to think we probably have more people signed up for this than we do for our annual conference many years. And so showing the upside of all this electronic life and virtual life that we lead. So this is a really exciting seminar for me. I think it's, all of them have been terrific, and I encourage you to check out our YouTube page. I'll put that in the chat, the link to that in a little bit, where we've uploaded the past presentations, and I think they've all been really excellent. This time we're hitting a really topical approach to electrocardiology, the use of artificial intelligence, and generally, I would say, digital tools, large-scale data, and how it affects our mainly, I think, clinical perspective. But I think there's a lot of great fundamental engineering here to at least appreciate, if not to fully understand. So. We have two fantastic speakers. Tom Ribeiro, you probably know the best. He's the president of our society for the moment. And we've mostly, I think most of us have heard him speak at some time in the past and know what amazing research he's been conducting and large-scale telehealth and gathering large data sets and analyzing those and distributing that information, connecting people around his part of the world. The new speaker for today is Francisco Lopez-Jimenez. And he comes to us from the Mayo Clinic, and he really has emerged, especially in the last few years, as one of the leaders in the applications of modern data analysis, machine learning, artificial intelligence in our field. But he has a long-standing and amazing publication record. He's got an incredible H-index. He's been very interested, especially in preventative medicine, where he's actually chair of the Division of Preventative Cardiology in the Department of Cardiovascular Medicine at the Mayo Clinic. He's focused a lot on the role of obesity and lifestyle generally on cardiovascular health, and has a number of really leading publications in that area. And like I say, in the last few years, has really emerged as one of the leaders in the use of these modern data analysis technologies, broadly speaking, to the kind of data sets that electronic records have now made available to us. So I think we'll be really keen to get maybe his talk we'll do first and get some really great background and insight into this whole approach, and then have Tom give his presentation about his use of some of these techniques. We're going to do it as we have in the past, basically do the two presentations more or less back to back, with questions at the end. I encourage you to use the chat window, which should be open to everybody. Place your questions there. I'll try and keep track of them, and we can pose some of them. If people want, I can unmute you, or you can unmute yourselves if you want to pose questions. I would just ask, and I may impose this, if you're not speaking actively, then please mute your microphones just so the speaker and the rest of us are not disturbed by any kind of background noises of, dogs barking or objects falling off our desks. So with that, I'll happily hand the chair over to Francisco Lopez-Jimenez. And Francisco, please.
Well, thank you for the great introduction, and for the very nice introduction, and for everybody being here. It is really my pleasure to be speaking to a group of people with a lot of strong interest in electrocardiography. I have two disclaimers before I start my presentation. The first disclaimer is that I am not an electrophysiologist. I'm a clinical cardiologist, and therefore, my understanding of the complexities of the electrical system of the heart are limited to what that of a clinical cardiologist will get in our training. Second one is that we had been obtaining intellectual property for pretty much everything that I will show you. So there is the potential to benefit in the future financially from the commercialization of those things. But as you know, when we talk about benefiting from commercialization when you work in a academic institution, you end up with a 0.00001% of whatever is sold. Okay, so probably some good for my coffee in the morning, perhaps. But so as you know, electrocardiography is very old, and it's one of those technologies like the bicycle and the typewriter that, you know, when it was invented so well that the fundamentals barely change decades later. So to that end, even though the size of the electrocardiogram has shrunk dramatically, and now we have electrocardiograms that are, you know, electrocardiographic machines that are pretty small, the way we interpret it, the output of this hasn't changed much. Actually, the same rules to interpret the electrocardiogram for the naming the waves and the segments and everything else has basically been the same. So we're talking about all technology that has been helping cardiologists and clinicians to identify myocardial infarction, arrhythmias, to find those with hypertrophy and those with risk for sudden death. So an extremely useful tool over more than a century. So the question that we posed years ago, considering the how pervasive AI was becoming a few years ago, the question was, well, can we use AI to do what humans do when interpreting the electrocardiogram, so we can facilitate the first pass interpretation to help in the triage work when we read hundreds of electrocardiograms in a given day, to make the use of electrocardiography more scalable. So any place in the world, any corner in the world can actually have access to electrocardiograms interpreted in a way that is so reliable, matching the human accuracy. But the other question, which is probably even more interesting, is can we use the electrocardiogram to see beyond what the human eye can see? Can we diagnose things that right now we don't have any criteria to diagnose using the electrocardiogram? Things that will escape to our interpretation, because what we will see in front of us is a normal electrocardiogram, but that electrocardiogram that seems normal is telling us something else. So that was the second main question about this, and perhaps the most interesting, and the one that I will focus on in the following minutes. So just a general description of what neural networks are, which is one of the core tools used in machine learning, which is truly the right way to describe what we do. Is not artificial intelligence, but more specifically machine learning, which is essentially getting a computer to learn patterns and to learn from its errors to come up with correct labels of diagnosis or medical conditions, etc. And it actually follows a very similar pattern that what our brain follows. So that's why this is called neural networks, because we have convolutional layers that sequentially keep learning, and then you have an eventual output that is the result of all those interactions that follow, if we want to put this in mathematical terms, follows non-linear math or non-linear reasoning. So essentially what the machine tries to do is to minimize the error with what engineers call loss function, so which is essentially the amount of error or the size of the error. The other thing is that AI doesn't have explicit rules. So you can actually let the machine learn, and the machine is going to tell you patterns that for you may not make sense, but the machine is telling you, well, this group behaves very similar in a number of things. So you human need to figure out what is common about it, okay? And that's why in the next 5 years, I suspect that instead of calling type 1 and type 2 diabetes, we will call those in different ways that will be clustered according to what the machine identifies as probably more meaningful grouping patterns. Well, so after that brief introduction on machine learning, let me just go directly to what is the clinical application of what we have been doing and what other groups are doing right now. So let me show you this study on hypertrophic cardiomyopathy. For this study, we analyzed the electrocardiograms of a little bit more than 3,000 patients with clinically and echocardiographic confirmed diagnosis of hypertrophic cardiomyopathy. And also more than 60,000 controls, people in which the diagnosis had been ruled out, essentially because the electrocardiogram did not suggest hypertrophic cardiomyopathy. It is not that it was suspected in all those 60,000, but just 60,000 echocardiograms where there was no evidence of hypertrophic cardiomyopathy. And a standard procedure we do in machine learning is to have a training set to train the machine, to train the computer. Then we validate, which is kind of a cleaning the data, cleaning some of the neural networks. And then essentially we create an algorithm that we believe is good. Then we test it, and we test it in a completely different data set with patients that were not included in the training or the validation set. So that's what we call the testing set. So we did that with 13,000 pairs of echo and ECG. And the results are there. So the area under the curve for the testing, which is truly which matters, is the one that tells us the validity when we try to use in clinical, in the clinic. The area under the curve was 0.96, which is pretty high. So for those who are not familiar with the interpretation of area under the curve, the perfect diagnostic test will have an area under the curve of 1. Now, no test has that. Random, diagnosis by chance will be an area under the curve of 0.5. And generally speaking, everything we do in cardiology will have areas under the curve between 0.7 to 0.85. Stress tests, troponins, CKMB, and so forth and so on will have areas under the curve around 0.75 to 0.85. So areas under the curve above 0.9 were unheard before AI came. So now let me show you this example. So this is a 25-year-old woman with this electrocardiogram that, I will give you a few seconds for you to take a look, but truly it looks, I will say, either completely normal or near normal. I see some non-specific ST changes right here, but other than this, looks pretty normal to me. It was actually interpreted as normal by the regular ECG machine, but the ECG, when we analyze this with our special algorithm for hypertrophic cardiomyopathy, the output was that there was a 72% probability that this patient had hypertrophic cardiomyopathy, and sure enough, the patient had hypertrophic cardiomyopathy. The patient was assessed, underwent septal myectomy because of a very significant gradient and symptoms, of course. But what's very interesting is that this is the electrocardiogram after the surgery. And actually it looks probably more abnormal than the first one. But when we run the algorithm, the ECG using AI tells us that the probability for hypertrophic cardiomyopathy is only 2.5%. Now, of course, the patient still has hypertrophic cardiomyopathy, but after the surgery, hemodynamic changes occur that the machine is telling us that the fundamental obstruction the patient had is gone. So let me now move to atrial fibrillation. So we all know that detecting atrial fibrillation is very important to prevent stroke and disability. We also know that detecting paroxysmal atrial fibrillation is not that simple. We need to put patients on holters, continuous ECG monitoring for weeks or months, and sometimes we have to either implant a device so we can track it for months because we suspect the patient might have atrial fibrillation. So the other problem is that in many cases, we know it is actually asymptomatic, completely asymptomatic. And in many cases, stroke is actually the first clinical manifestation of atrial fibrillation, and it's too late at that point because we realize the patient has atrial fibrillation after having the stroke, undergoing extensive cardiac workup, ECG monitors, etc. And then we find out that the patient has atrial fibrillation. So the question is, can we diagnose atrial fibrillation even when the ECG shows normal sinus rhythm? So to do it, what we did was to analyze these 1 million electrocardiograms in about 210,000 patients. We excluded a number of those individuals because, well, some of those had ECG in the, AFib in the ECG. So obviously we exclude those. Others that were outside of the window of our study, some of those electrocardiograms were not digital, so we could not analyze those. So our final sample was 649,000 ECGs in 180,000 patients. We split it, as I mentioned before, in the training data set, in the validation data set, and in the testing data set. And this is what we got. We got an area under the curve of 0.87. Now, when we refined it, excluding patients with technically difficult ECGs that had a lot of noise, that was about 5% of the ECGs, then the accuracy improved to 0.9. Again, it's an excellent area under the curve, much better than what we have for a treadmill stress test, for a nuclear stress test, and for many other things we do in medicine. For example, the area under the curve for mammogram that is used everywhere to identify and screen for breast cancer is barely in the 0.78, 0.8 area under the curve. So good accuracy. So let me show you this. This is a real case where what you see right here is a graph that in the y-axis is the probability to have atrial fibrillation according to the AI analysis of the ECG. In the x-axis, what you have is the timeline of all the electrocardiograms performed since 1988 to the year 2020. In blue are those ECGs that the ECG AI output is telling us that the probability to have atrial fibrillation is actually very low. Again, those are all ECGs in sinus rhythm. In red are those ECGs that the machine is telling us that, that there is some probability to have atrial fibrillation. And the probability, again, the output of the machine is not a yes or no, it's a probability. And the probability can go from 0 to 100% or to 1. And we set the threshold at which we might have some clinical value. So we have been using a probability of around 10%. And as you can see here, in 2002, 2005, there were already several electrocardiograms suggesting that the patient had paroxysmal atrial fibrillation. But the patient actually presented with the first stroke in 2015, still normal sinus rhythm. And sure enough, the patient did not get any anticoagulation because the patient had no atrial fibrillation that was documented so far and underwent the usual monitoring with Holter, etc. And still no evidence of atrial fibrillation, even though the ECG is telling us that the probability was very high to have atrial fibrillation. Patient got a second stroke right here. So 2 strokes, and this is the first ECG showing atrial fibrillation. So the question is, could we have prevented this stroke by putting the patient on some medications since 2005, or even after the first stroke to prevent the second stroke? So it's an important question for us to ask in the next in the future as we continue working with AI. So see how this electrocardiogram that is already labeled as possible paroxysmal atrial fibrillation, even though it's in normal sinus rhythm. See how it's a completely normal electrocardiogram, that there is no way for me to think about the P wave is completely normal. I don't even see anything that will point out to a big left atrium, a big R atrium, or anything that I will say, well, that's predisposing the patient for atrial fibrillation. Now, I think this is the last case. I want you to look at this electrocardiogram to tell me if you find anything else that will seem abnormal. This is a 35-year-old man that presents to the cardiology service because his sister died suddenly. So this electrocardiogram was actually interpreted as normal. You might perhaps say that the S waves are a little bigger than normal, but actually it doesn't meet criteria for hypertrophy for what I can see here, and the machine reads this as normal. The ECG output is telling us that there is a 76 probability that the patient has low ejection fraction, which is actually one of the first algorithms we created here at Mayo Clinic. We did an echocardiogram, and the ejection fraction, sure enough, was very low, 18%. Again, with an ECG that will not suggest anything that, for what we know, correlates with low ejection fraction, like a left bundle or just a widening of the QRS. So again, we developed this model to detect low ejection fraction with a neural network system, and the accuracy is 0.93. Now, as you see, every time I talk about the accuracy, I talk about the area under the curve. I don't specifically mention sensitivity or specificity because the sensitivity and specificity is a trade-off of whatever you choose to cut the curve. But when you have an area under the curve of 0.93, you know that both sensitivity and specificity, when you cut the curve any place around this area, both will be actually very good. So let me show you this case. The application of this algorithm in this particular patient, again, the ECG was not particularly abnormal. The algorithm actually labeled this as low ejection fraction, but the echocardiogram shows an ejection fraction of 50% that is not completely normal, but it's not necessarily low that will prompt you to do anything else. You know, it's borderline, we can say. So it's officially a false positive result for our AI algorithm to detect low ejection fraction. But the question is that truly a false positive, or is that telling us something? Well, what we did, we analyzed all the false positive results for this algorithm. And what we found was very, very interesting and very impressive. Patients with a false positive result for low EF, again, they had a normal EF, but the ECG labeled them as low EF. The incidence of a low ejection fraction over time was 4 times higher among those who were tested positive for the low EF algorithm. And we just finished another analysis that regardless of the ejection fraction during follow-up, the likelihood to develop clinical heart failure is 3 to 4 times higher among those who are flagged as positive, irrespective of the ejection fraction value. So it might be a way perhaps to detect those at risk to develop low ejection fraction in the future. In this particular patient, the ejection fraction 5 years later was 31%. Just to finish, let me tell you about other algorithms that we have been creating in the last 2 years. We have one to detect long QT when the QT is completely within normal limits in that particular electrocardiogram. Very accurate algorithm. We hope to apply this to people with history of family history of sudden death, those with suspected long QT, but every test shows to be normal. We just finished an algorithm to detect coronary calcification that, as you probably know, this is a test we use to do risk stratification for coronary disease. Very accurate to detect people with coronary calcification. We have another one to detect pulmonary hypertension. And we know that there are some ways to detect or to suspect pulmonary hypertension in the ECG. That's not new. But what is very interesting is that when we apply this algorithm to people with a completely normal ECG, the accuracy to detect pulmonary hypertension is still pretty high. So there is something that the ECG can see that we humans probably don't see or still don't know exactly what is causing that. Now, what is really amazing is when we go beyond the heart, when we try to detect things beyond the heart, it has been actually very accurate to detect other things. For example, we can predict the gender with almost complete certainty. We can tell you who is a man or woman just by the output of the ECG. Now, this might sound totally irrelevant because you can ask the patient, well, you know, is it a man or a woman? But we have shown that when patients get anti-androgen therapy for prostate cancer or anti-estrogen therapy for breast cancer, in a number of those individuals, the gender actually flips to the other one. So it's something for us to think about the potential applications in the future. We completed a multi-center study to detect COVID-19 with the electrocardiogram. Now, the accuracy wasn't perfect, but again, was better than the breast cancer that we use every day to detect, to screen for breast cancer with mammograms. But, you know, is there any use for this? We believe that if you set the sensitivity and specificity in a way that you optimize the negative predictive value, meaning that if the test is negative, the chances to have COVID is close to zero. You know, why not to use this in airports or in places where it's very important for you to know if the patient has COVID right there on the spot in 10 seconds. And finally, a group of gastroenterologists partnering with some of my colleagues here in cardiology tested a model to detect liver cirrhosis. And the accuracy was amazing, was actually more accurate than even the ultrasound of the liver. So, you know, believe it or not, the ECG might detect liver cirrhosis. And this is expanding to areas where we might never imagine this was actually possible for the ECG to detect. So in summary, the AI-based interpretation of the electrocardiogram has major potential. It has the ability to see things that the human eye still cannot see. We don't know exactly how this happens and how the machine can detect those things, but it's happening. So the main question is what other old tools we have, not only in electrocardiography, but in cardiology in general, in medicine in general, can be repurposed to diagnose things that we didn't know those tools can help us for. Thank you very much.
Fabulous, thank you. I think that certainly lays out the promise of this technique really well. It's amazing the diversity of applications you've already documented for us. This is fantastic. And there are questions appearing. Please keep adding those to the chat. I'll keep track of them and we'll get to as many as we can once we hear our second speaker. So again, Tom Bair needs no introduction to all of us. He's the president of our society, and he can hopefully, yes, I see from the title here, mix in his longstanding interest in telemedicine with some new applications using some of these machine learning approaches. So Tom, the floor is yours.
So first, thank Rob and thank a lot Francisco for joining us and giving this fantastic lecture, and also to be open to discuss with this group of persons that, as you said, they have been interested in ECG now for a long time, and it's very good to be new applications, new ways of seeing this old method. And I will try to summarize our experience that, as Rob said, began with the tele-ECG, with some of our experience with artificial intelligence, indeed with machine learning. So I'm Tom Ribeiro, I'm from Belo Horizonte, Brazil. And first, only to say where you are, what we do. We created this telehealth network some 15 years ago in the southeast state of Brazilian state. We began as a telehealth network, is a feasibility study of implementing this telecardiology system in this remote place of the state of Minas Gerais. We are, since the beginning, a network of universities working together, public university of the state of Minas Gerais. And we use it always low-cost technology, simple ECG machines, and also standard computers, and to try to have a service that can be applied everywhere. So the system was really a success, and it was expanded by the state of Minas Gerais for almost all municipalities, and now, and by the end of 2010, 2011, we are covering most of the municipalities of this state. And we also expanded our activities to other fields of medicine and health. We began to do research with this data, and also we have a teleeducation channel for cardiology and for other fields. So we are indeed a telehealth service in which cardiology and tele-ECG is one of our main activities. Now we became a national service, and we are providing tele-ECG for the Amazonian region, for the northeast, for the center part of the country, Bair state, and we are performing something like 3,000 ECGs a day for 9 Brazilian states and more than 1,000 municipalities. So the system became the official partner of the health ministry for providing tele-ECG, and we are expanding our activities for the other states. Well, our system is very simple. We use a system that ECG uploaded from patient to our server. Now we do not have this reading room, this specialist room. Our specialists use a web-based system. They read the ECG, they analyze from their office or homes, and then they upload the result that it's delivered at the health unity everywhere. So we developed our own system. So the ECG system can capture the ECG signal from different ECG machines. We did a lot of development trying to standardize this ECG web-based report system. And we work 24 hours a day. In general, our urgencies are answered in less than 10 minutes. And the median value is 2 minutes, and the routine exams in less than 2 hours now. In general, 30 to 45 minutes. So this is a very heavy assistance service. But we began to do research with these ECG systems. Mostly, there are a lot of research on this database, and Mirena Marcolino and Daniel Palhares, the first studies, some of them in collaboration with Peter McFarlane, a lot of epidemiological studies and reference value studies. But then we thought about the possibility of using AI in this data set. And we, as all that are beginning in this field, we read the Eric Topol book, and he's very harsh with the ECG in this 2019 book, saying that this ECG has been read by machines for decades, but indeed it's surprising how little has been done with modern AI tools to improve ECG interpretation accuracy. I think Eric Topol by this time did not know Francisco Lopes Jimenez and the Mayo Clinic team, because by this time a lot of things have been done from 2019 on. We have not only by the Mayo Clinic group, but by other groups, a lot of new applications for AI in ECG. And when we try to understand why machine learning was not so widely used in ECG, we can see that many studies have very limited goals, and there is a scarcity, there's lack of large annotated database that include major ECG abnormalities. Now we have more, but by this time it was not so easy to get. There are the PhysioNet ones, and so, but we really need large data sets in which we have different exams. So many hospitals and health systems archive the ECGs as images or PDFs. So not as the signal itself. So this also was a problem. And most of ECGs have some kind of free text reports or automatic reports. They were not reviewed by a medical doctor. And also there are a lot of the ECG classes are very, there are many, the number is very high, and they are unbalanced. We have very rare abnormalities and other very common, and also a lot of variability of interpretation by medical doctors. So there are problems with ECG database. And then we decided to create this code study, clinical outcomes in digital electrocardiography. First, we got the ECGs from 2010 to 2017, from it's near 2.5 million ECGs, 1.6 million persons, and we linked them. We did duplicate, find the same person inside this database, and link it with mortality data, and more recently to hospitalization data from the public health system. So we got a large data set with the ECG signal, but also some clinical data, like some medications and some self-reported conditions. And we have the outcome for this electronic cohort. So this became one of the largest data set we had in this Mayo Clinic study published very recently by trying to summarize this find, show that this is one of the large data sets we have now. So this is an old diagram showing that for each patient we have exams, sometimes more than one exam, to 1.6 million patients. We have 12 leads, so per tracing. Sometimes we have several records for one ECG, at least 2 or 3. And we have the free text report, but we have with the collaboration of Peter McFarlane, the Glasgow classes and also the Minnesota code. And we did we tried to get these in something that we call code classes that are mostly the American Heart Association list of diagnoses. And we tried to get these for this cohort of near 1.6 million unique patients. We try first to do epidemiological studies. So we got the first ECG for patients over 16 years old, and excluded those with not readable ECGs, and tried to understand what happened, for example, with atrial fibrillation. The first ECG has an AFib. This was the master thesis of Gabriela Paixão. Was presented in ISE and ISE, ICE meeting and ISE meeting, and showing that when you have this electronic cohort, AFib is a very strong marker of risk in this community-based persons, and that the advantage that woman has over men in terms of survival, when they do not have AFib, it's lost when they have AFib. So the risk of death when a woman has AFib is higher than when a man has AFib. It's not a new finding. There are other studies showing similar results, but it's we have a very robust data with very narrow confidence interval showing this. It was for us a proof of concept that we would be able to use this type of sample for this kind of study, and we did the same for a bundle branch block, and it's impressive to see that indeed the risk of death, of being dead with left bundle branch block is smaller than the AFib itself, and not so different the right bundle branch block that we consider much more benign than the left bundle branch block. So we can have a lot of information in what you have in the community for different ECG patterns, standard ECG patterns, and try to reposition these risks according to very reliable data. So this is it's another study now from the PhD of Gabriela. We did a study on classification of ECGs, and this was published last year in Nature Communication. It was presented in several of these congresses, and Antonio and Manuel, as Gabriel and others are the first authors, and we get the sample. We show 6 abnormalities, original abnormalities, but also morphological ones. We reviewed this data set for trying to get the label, the adequate label, and we use both the automatic measurements like the outputs of the Glasgow software and the Minnesota code software, also by Peter, but also using natural language to get the diagnosis from the free text medical report. But we had to review thousands of exams to get these labels. And we compared the machine with medical residents, 4th year medical residents, 3rd year emergency medical residents, and 2 medical students. And indeed, we showed that according to our metrics, the machine in blue is as good as the medical doctors, the medical residents. And in general, it has the best position, but it's not statistically significant from the medical doctors, showing that it's possible to train. We use the same structure that Francisco said. We have a training set, validation set, and a testing set. This was in the testing set, showing that machine can classify very, very adequately, very well the common ECG abnormalities. So we are studying other fields now and try to explain the end-to-end ECG automatic classification, try to use ECG to predict prognosis, also the long-term AFib with ECG can. We know that the Mayo Clinic and now the Philadelphia team did the same. And we're working together with Francisco and the Mayo Clinic team to predict left ventricular systolic dysfunction in Chagas disease. Let me show you a little on these studies. This is a PhD student of Derek Oliveira under the supervision of Wagner Meira from the Computing Science Department, and was presented in several meetings. And what Derek is trying to do is to include a noise generator and trying to modify the components of the ECG to give an output for the medical doctor, that how the machine reached this diagnosis. So it's a very simple exam. We first do the plot. We do not need any sophisticated things for doing this, but in this case, what he found that the machine has my God, a cat. Sorry for this. Cats in Zoom meetings are a classic. And so trying to give a written report for the cardiology in a way that they can understand why the machine did found this ECG, and this system is being tested now in a new experiment according to the accuracy of the system, how relevant is the explanation for the usage, and how it's the fidelity as another feature. So it's an ongoing research, and we also are trying to understand the capacity of DCG to predict the age of the patient. And this is something that Francisco and Zaki from the Mayo Clinic had published one or two years ago. And when we used our data set, we divided it in 85% to develop the model and 15% to evaluate. And we calculated the error. So the mean error of the machine to find the age of the person is around 8 years. And so we tested the prognostic value of the ECG age in a subsample of the code study, the 15% and 2 other cohorts. And what we found that these cohorts are very different. So the code study is mostly from primary health care. This is a study from Emily Lima, Antonio, and Gabriela.
ROC, že vlastně kdyby, jak se to zná, že se to...
And so the code study is a primary health care sample. The ELSA study, it's a study on labels in the university, and the Summitropy is a sample of Chagas disease patients. So we tested this age predicted, this ECG predicted age calculation in these 3 different cohorts. And what we found is that when the age predicted by the ECG, it's 8 years or more than 8 years older than the current age, we have that the risk of death is higher, the survival is low in the code study, but also in the ELSA and in the Summitropy. And then when the ECG obtained, the age obtained by the machine from the ECG, it's more than 8 years younger than the current age of the person, we have some kind of risk reduction, and mostly in the community and normal person cohort. In the Summitropy disease, it was not significant. In the Chagas disease cohort, it was not significant. So this was important increase of risk of 80% for the code in the ELSA cohort, and more of these for the Chagas disease cohort. And the reduction of risk is from 20 to 30% for these cohorts. This risk and this protection was maintained for when we correct for risk factors that are available for this cohort, showing that it's not completely related to this. The strength of the relation, it's reduced mostly in the ELSA cohort, but we can see that it's some kind of independent prognostic factor. Then we go to the normal ECGs, and in normal ECGs, we could still have the same effect. So those persons with predicted age higher than the current age of more than 8 years, they have increased risk of death, mostly in the code study, is the largest one, even if you correct for risk factors. In ELSA study, when you correct for risk factors, probably by the sample size, we lose the significance of this. But it seems that so the ECG age is not only a summary of the ECG abnormalities, but that there are something in a normal ECG that can show that this person is older, the body, the heart of this person is older than what's expected for its age. And we try to understand, we do the automatic measurements for these groups, those with younger than 8 years, older than 8 years, and we could not find significant change in ECG measurements. Although they are significant, they are very, very close one to the other. And we try to understand about how we can interpret this. So first we did an experiment that we showed paired ECGs, persons from the same age, that one has a chronological age of more than 8 years than the estimated age, more than 8 years than the real age. And we showed 3 cardiologists and asked them to to say which one has is older than the other. And we could not find any kind of pattern. We did three types of experiments showing data, trying to teach them, showing what the machine was doing. It was not possible to see any kind of, the cardiologist cannot recognize this information. We also did salience maps highlighting the regions of the ECG in where we can find it's more affected by the ECG age, and we can see that the whole ECG, but mostly the P wave and the T wave are very, very marked in this case. We also did the salience maps using trying to understand the frequency in which it's more modified by this kind of modification, and we can see that the low components from 8 to 15 Hz are the most affected by the ECG predicted age. So we can imagine that ECG age can be maybe incorporated as a simple way of trying to reclassify risk. For example, those in the intermediate risk of in primary care, and since a method that is widely available, and these are hypotheses that use that should be tested in further studies. We also tried to understand the prediction of long-term AFib. In the Mayo Clinic first study, they were able to find AFib in a shorter way, and now they are also showing that it's possible to predict AFib in a longer way. And this is a collaboration with the Technion team, Shani Beaton, Shayna Genderman, and Joaquin Bair. And we provide this team from the AIM lab, our DNN and also our signal. They extract not only the DNN features, but also morphological and HRV features. And this is with machine learning methods. They are getting results about the possibility of recognizing those from those 400,000 patients that have at least 2 ECGs. We got a team that excluded those with AFib, and we got those who have atrial fibrillation in the second ECG, and then only briefly showing that there is a very good performance of the method, 90%, 0.9 in the Hock curve, as using this model that includes not only the DNN but also morphologic HRV is some clinical features. So some kind confirmed that it's possible to use ECG. Those with normal ECG has features that can recognize those who will develop AFib in the future. And then this last study, that's a collaboration with the Francisco Jimenez and Zaki Acha Zaki, and they showed that it's possible to predict left ventricular systolic dysfunction using the ECG. This is Nature Medicine paper. And then we used the same software provided by Acha and Francisco in our Chagas disease cohort, and showed that in this very different setting, the artificial intelligence predicted left ventricular ejection fraction is highly associated with the presence of left ventricular systolic dysfunction in this sample, the area under the curve of something like 85%. And this is something that is to be published very soon. So what are the challenges now? The first challenge is to have a system that can classify the ECG, the complete classification of the 12 leads. That's not a simple task. We need to test and try to see how we use these prognostic markers that we are the new markers, the standard one, how they can be used in clinical practice. But I think that the most challenging thing in ECG is to improve the access to ECG and to cardiovascular care to the whole world. We know that we know that in the US, in Europe, and Australia, Japan, we have an excellent access to health, to ECG. But you know that in most of the Latin America, Africa, and part of the Central Asia, this is not the question. So if you have automatic classification of the ECG that's accurate by improved by artificial intelligence, it can have information from the ECG. ECG is a low-cost method that can be used everywhere. It's very easy to use using telemedicine. So there are a lot of possibilities of using this to achieve the sustainable development goals of good health and well-being for all, and also to reduce inequalities in health. This is not a single person activity. The code study is a group of multidisciplinary group of persons from different fields, some now in Uppsala, and there are also other collaborations with other teams that are not, we do not have results, and we are using this data set to try to improve this kind of collaboration and obtaining as much information as we can. So thank you. Let's talk about this.
Yeah, great. Thank you, Tom. That was fantastic to see, you know, not just the technique and its achievements, but also this perspective on worldwide delivery of healthcare. I think that's a really important perspective to see these tools in. And let's get started with some questions. They fall into a couple of categories, and we may get short on, we already are a little short on time, so we may consolidate them a little bit, but they tend to fall in a couple of categories. And one is sort of about the data sets and you know how to create those data sets, and the other one is how to interpret the results of neural networks. So I'll open with a question from Case Fain, who says, you know, what about the HCM examples in the beginning of the presentation? So this is related to your presentation, Francisco. A low probability after the intervention is, to my opinion, only saying that the ECG does no longer belong to anyone in the known HCM cases in the database, but it does not tell us that the HCM has now disappeared, unless you would have trained the algorithm, including a group of successfully treated patients. So this thing is one example of a larger class of questions of really how we form the right data sets. How do we decide who belongs? Do we need negative controls? You know, do we need post-op successful surgery outcome patients in order to maintain and maybe even enhance the accuracy of the algorithms? So maybe Francisco could take that one.
Sure. My response, I think, is going to cover several of the other questions as well.
Great.
So that's a critical point. And for this, it's important to mention that, you know, at the beginning of this AI revolution, those doing this kind of research were mostly engineers, computer scientists who will have no idea of clinical medicine, but just grab the data and analyze, right? So they see data sets from the mathematical standpoint. And that's when they talk about balanced data sets. What they want is a study where you have 1,000 patients with the disease and 1,000 patients without the disease to have it balanced. But that's not what we see in clinical medicine. So the other situation, which is also a very common, I consider a mistake, is that engineers test those with the classic, you know, straightforward, typical presentation of something and compare this to normals. And the classic example is, you know, there is a beautiful algorithm, beautiful because it has a very high accuracy, is detecting children with autism with a video. You know, you do a 10-second video and the machine can tell you what almost certainty that the kid has autism or it doesn't. But guess what? They only use children, like 100 children with classic autism, that anybody will say there is something wrong with this kid. You know, this kid is abnormal, has something going on. And 100 completely normal children. So, you know, it's like trying to teach a computer to differentiate horses versus cats. You can do that, but the question is, will that model differentiate horses versus zebras, horses versus donkeys? That's a different thing, right? So in medicine, that's what we do. We deal with patients that have conditions that in some cases is a clear-cut condition. In others, it looks like it has the condition, but it's not the classic presentation. And there are other conditions that simulate the condition we're trying to diagnose. And that's why we believe that a fundamental principle in machine learning is that your group of patients with the disease has to have a broad spectrum of the disease, the whole spectrum that you can see. And the controls cannot be just normal people. It has to be a group of individuals similar to what you see in your clinic, a whole spectrum of patients without the disease, which is normal, those with conditions that simulate the condition you are trying to diagnose. And this is the only way you can avoid what is called a spectrum bias. So when we are trying to balance, what we are doing is we're creating a spectrum bias, because when you select that, you will very likely limit the spectrum of the individuals representing either your cases or your controls. That's extremely important. And I think that answers some of the things. Now, there is a question about how we tested the algorithm in trying to predict something that it wasn't intended to predict, just to prove that it's not guessing. We have, and indeed, when we are trying to predict atrial fibrillation using the low EF model, it doesn't perform because it wasn't set for that, which is essentially another reason. But what is interesting is that when we are trying to predict things that we were not supposed to predict, like gender or even age, as Tom mentioned, guess what? The computer is able to see. Now, there is a question, and this is my last comment. There is a question out there whether we have been able to identify the features. The question is, the simple answer is no, we haven't. And this is what is called the black box. Now, the question is, do we really have to identify those features before we use this in clinical practice? Do we have to understand all the details of why the ECG can detect atrial fibrillation, even if the ECG looks completely normal? I think it's an interesting question, but I don't think it's a necessary question to use it. Because if I tell you right now, I have this wonderful AI machine that can tell you which stock is going to double in price in the next week, with 100% certainty, would you care about knowing what is predicting before you apply? You'd say, get it, give it to me, I will use it. And then you will double your investment because you care about the outcome more than what the predictability, basically.
Yeah, thank you. That does address a lot of those questions. And I want to hear from Tom too, but I want to add in another aspect of the question related to data and ask Tom to address. This came from Johan de Bie. Many large hospital ECG data sets do exist, but they're not generally available. They're just sitting there, or at most just used locally. How can we stimulate that those become broadly available? Even if these would become available, they are often badly annotated. Suggestions how to improve the truth annotation in order to make them more useful for AI-based development. And I think this is a question you've certainly addressed. How do you deal with data you can't get at, data in old formats, data that's noisy, data where the annotations aren't good, and where are we on that, and where could we be going to improve that situation?
Yes, indeed, I have seen in this audience very persons that are related to several societies of ECG, and I think that we should try to first to standardize a little better our diagnosis. I saw the last CNC, the FusionNet challenge of ECG classification. And I was a little astonished that the classes that were used in some of the samples are not mutually exclusive, or sometimes you have the same name in two different classes that were considered different from different names for the same thing. So there are a lot of confusion, and Peter is here, and I think that those who develop classification system, reporting system, probably did an excellent job in trying to have the different classes. But sometimes we also have a too large number of classes with too subtle difference between them. So if we go to the output of the Glasgow system, we have 700 statements. And so there are some things that I think that the ECG societies and could try to do is to try to standardize and to get those previous reports from the ISE and the American Heart and the American College and try to implement these in a way that people can give the report in the same way, because the free test is a very difficult situation. We have this large service, we have several cardiologists working, reporting ECGs, and we have a lot of work trying to standardize the way they do. Now our system limits their choices to a number of classes, a number of diagnoses, in a way that they can know what they are doing. And now our the variability among cardiologists in our audits are showing that this is reducing, and we are having less problems with this. But so there are a lot of first front will be trying to have real good at the SNOMED in everywhere, that are really have reliable classes for ECG that is, can be used the same way everywhere. The second way is trying to discuss with the companies and those who get with the software. It's a pity that most of ECGs are not being kept as the signal, but only as the JPEG or the PDF. The PDF is a little better, and there are even some formats of PDF that can retain the signal itself, but in a way that it's obvious that it's possible to recover the ECG signal from the PDF, but then we'll have one more transformation. You can lose information, you can get noise inside. And I understand that those places that, like the Mayo Clinic, like the Philadelphia team, that were able to keep the ECG as the signal, they are in advantage when you consider that those are keeping only the imaging. And I think this is something that should be discussed with the companies, and I think that's another front. The third one is how to clean it. And if I have this answer, I would become rich or something like this, or at least happy, because we are able to reveal not very common abnormalities with a team of cardiologists and students, and it's a very labor time-consuming task. So we did some kind of heuristics and tried to use the automatic measurements along with some labels that we can recover using natural language processing from the free text report. But indeed, it's we need to review a good number of ECG tracings by hand, so to see one by one, to classify them as the labels. Maybe some of these heuristics rules can be, we can try to publish it and try to understand how we can do this for a larger, not only for our sample, but for the whole group of hospitals and teams that have data like this. Sorry for the long response, but I think it's a difficult question with different fronts of action.
Yeah, no, thank you. It's very comprehensive, very helpful. I'm going to take the moderator, prerogative here, ask the last question, because we do need to wrap up. And it's to both of you. I'd like to hear both of you comment. When I first started here about machine learning approaches applied to ECG, they were focused on parameters. So there was an initial pass, and Tom, you described some approaches where you went down this route, where you extracted parameters, then fed the parameters into the algorithm, and then we transitioned into this period where it seems like the entire signals now go into the algorithms. And I'm curious what your perspectives are. Is there any utility, except maybe some data efficiency, that we may or may not care about for using parameter-based approaches? Or should we just be working under the assumption that we're going to be throwing entire signals at these deep neural networks and get solutions from them? So is there a place for parameter-based approaches, or are we in this kind of signal domain? So maybe Francisco first, and then Tom.
Sure. Well, in my opinion, there is no reason to go back to parameter-based analysis. And the reason is because the only reason you will do that is if the computer capabilities are limited, which is not the case. Going back to, for example, think about the Framingham-Rees score. So we use, we try to predict cardiovascular events using very simple parameters with that restriction. And the only reason we did that is because we wanted to predict that using a piece of paper and a pencil and doing a math calculation and say, well, your risk is higher or your risk is low. These days, there is no reason to limit ourselves to that. And the other factor is that why to limit the input to specific things when the computer can actually see the whole picture. And especially because we don't know, and we have shown that just the parameters cannot reach the level of accuracy when you use the whole thing. The point is, I suspect the machine is using some subtle electronic signals, or I call signature, or a digital pattern that might be related to how those different parameters relate, not necessarily to what each parameter can tell you. It's just going with the whole thing and see what happens. And actually, this is probably going to be the case in many other things. In radiology, they are moving from annotating. What they do is they train the computer about the different, they split an X-ray in 1,000 different little chunks of the X-ray. So the machine learns what a chest X-ray is. Well, what they are doing right now is they feed the computer with the entire electronic signal, because that takes care of the whole thing, and the computer will put everything together and will realign everything, and it's going to create the picture, and that's essentially giving the whole amount of information, and the computer has to train. Now, for people just to have an idea, when we talk about training the computer, we are talking about the equivalent of 100 big like the computers you have, to have 100 of those computers working on this algorithm for 2 weeks, 24 hours. For 2 weeks, 100 computers to generate one algorithm. So it's a lot of work, but of course, it's not that we want the algorithm to be developed in 1 day or 1 hour. That would be my opinion. I don't know what Tom thinks.
The first time someone told me that they would like to extract the parameters and to get the whole tracing inside and see what happens, I thought the guy was mad. But what I think that it's technically our segmentation methods and methods of automatic measurement of the ECG waves and intervals, they have some error. And when you get these parameters and enter these parameters inside the machine, first you are bringing this error inside your machine, and the second is that you are seeing only what can be measured with these parameters. So I really do not know. I'm not an engineer. Please, can say something stupid, but maybe there are in different frequencies or different ways of seeing that things that are not there, and then if you only enter these parameters, you lose this complete information that you have with the whole tracing. So I understand that the parameters are very important to the interpretability question. This kind of study we're doing the segmentation to try to modify the waves and try to understand where the machine is finding the abnormality. But I really think that the future is deep neural network. I really think that we will use the whole tracings for more and more frequently, and it will be able to recognize features that are not recognized by the parameters itself.
Great. Well, thank you both, and thank everyone for participating. I think there are lots of other questions that we would love to be able to answer. This is where the digital paradigm breaks down. If this were a real conference, we'd be mobbing our two speakers and spend the evening talking about all the questions that have come up in our heads. And so we will look forward to a time when we're back in person and able to interact directly and with higher bandwidth. But I really want to thank our two speakers. This has been, I think, a great combination, seeing the potential and the utility and the impact of this approach on across all scales of space and disease. And so like I say, I think this was an excellent presentation. I hope you all enjoyed it as much as I did. Thank you both to our speakers. I know Francisco put in the chat that he'd be happy to answer individual questions. I'm sure Tom would be willing to do the same. So please, if you do have questions, reach out to our speakers and engage with them as best we can in these sort of limited situations we're in. And again, look forward in the next few days to a video. I'll mix down a video from today's presentation, get that up on our YouTube channel, and encourage you to view some of the previous seminars that we already have stored there. And with that, I'll close today's session. Again, once again, thanking our speakers so much and thanking you all for joining us. Bye-bye for now.
Thank you.